is the case of a 34-year-old IT professional and right-hand dominant personality, and he came to us with 3 days post fall from bike, history of 3 days post fall from bike, and as shown in the X-ray, he has hyperlaxity. He is having the swan neck deformity in both the hands, and that's a hyperlaxity by birth. But right now, his current problem is like flexion deformity at ring finger. So, may I request one of our delegate, like Dr. Bipin Ghanghurde. Dr. Bipin, is there anything special that from this X-ray and from my history that you would like to comment about the injury?
So I just want to know where is the swelling here? Which part of the
dorsal aspect of the distal interphalangeal joint.
Okay. So and is there any pain or tenderness in the proximal interphalangeal joint?
Not much. Reasonably normal.
Tender. Okay. So the distal interphalangeal joint is tender.
Yes. Yes.
Yeah.
So there is no active extension possible.
Okay. So on this X-ray, on the dead lateral view, I can see there is a chip fracture, chip here there is a bony chip basically.
Yes. Is this the chip you are talking about?
Yes.
Okay.
So I can suspect it as a mallet finger because in a hyperlax people they present like a swan neck deformity.
Yeah. Is Dr. Rohan online now? Okay. Dr. Amit, are you online? Yes. So, Dr. Amit, if you see a soft tissue mallet injury with the acute history, may I know what will be your approach? Dr. Amit Varhade?
Yes. First thing I will do, I will ask for ultrasonography, musculoskeletal ultrasonography to see the exact position of the extensor tendon.
Okay. And suppose the sonography suggests there is a partial rupture or sonography suggests a complete rupture. May I request you, how will you proceed?
Complete rupture of the extensor tendon.
Yes.
Then we have to repair the tendon, or if it is just near the insertion on the bone, then we can do repair it with pull-out suture technique.
Okay. So in this patient, so I did not do a sonography in this patient. It was a very classic. He presented to us 3 days history of a very classical soft tissue mallet injury. And as the X-ray showed, avulsed insertion of the the extensor tendon up to the middle phalanx level, I decided to consider, so repairing the extensor tendon with the suture anchor. So this is what these are the Shyam picture. First, I put the axial K wire, and then as shown in the picture, I have put a drill, for the anchor, and I have used a 1.5 mm. Yeah, so this is the approach for our soft tissue mallet. Okay, and hidden. And then if you see another video, so this is what the avulsed tendon from the insertion site. The extensor tendon was completely avulsed from here, and we did a fixation with the anchor. So I used a 1.5 mm anchor to fix it. May I ask Samrat, Dr. Samrat, is there any other way apart from anchor that you would have considered to fix up this problem?
Yeah, as Dr. Varhade said, we could have used a pull-out suture. That could have been done for the same thing if we don't have an anchor.
Acha. Okay. So what is your post-op protocol? So in this patient, I am going to keep my axial wire for at least 4 weeks, and after that, I am going to start active range of movement at DIP joint for almost another 4 weeks, and after 2 months, I will start passive range of motion at DIP joint. This is what is my protocol for this particular case. do you think by doing a pull-out suture technique, you can mobilize little early, or what is your post-op protocol, Dr. Samrat?
I would in any ways use this axial KY for 6 weeks and then start with active mobilization. And as you said, passive mobilization has to be almost after 10 weeks, because I have in these 10 years I have seen one case which just snapped off while doing passive mobilization. So we'll wait for the passive mobilization. It will ultimately come because FDP is a strong tendon. Yeah.
Okay. Is Rohan online?
Yes, Parag.
So Rohan, do you know any reference from any particular literature on this case, or you would have managed it little differently, or you would have given an attempt of conservative treatment?
Yeah, so I would have discussed conservative management in him. Okay. And if I'm discussing conservative management with him, I would have done an ultrasound.
Okay.
To assess how much of the extensor tendon is ripped off.
Okay.
Now, even if the fragment looks small, the entire extensor tendon might be off. So if you're going in for a conservative management, always do an ultrasound. But yes, if it's a partial tear, I would have conserved this.
Okay. So this was my first case. I will stop sharing the screen and request Dr. Bipin Ghanghurde to share his screen immediately to start with the next case. Yeah, Bipin, please share your screen. Meanwhile, any criticism about my case, or do you feel you would have managed it a little differently?
Parag, so I feel that what Rohan said, that I also will go ahead and do the ultrasound and see if the tendon is approximating before operating this patient surgically. Okay. I will do the conservative, and if it comes with conservative, I will splint it for quite a long time, and instead of operating before a month, at least a month, I will try conservative treatment before going ahead.
So the one message is very clear that I would like to give all the listeners on OrthoTV right now is, out of 6 of us, Dr. Amit Varhade, Dr. Rohan Habbu, and Dr. Bipin Ghanghurde, they recommend for a soft tissue mallet, you should consider a proper ultrasound to look for continuity of the tendon and consider a non-operative treatment with proper rehabilitation protocol. And if they don't improve, then to consider fixation. Yeah. Thanks. Dr. Bipin, please go ahead.
Yeah. Thank you, Parag. So this is a very unique case which I had managed. So I just want you to look at this X-ray. This is a 7-year-old child with this sort of X-ray. Has swelling of the little finger, right hand little finger. He's a cricket player, and the hand was jammed in 2 desks in the school, and he came with this picture. So what do you think is this type of injury? Can anyone comment? Parag? We cannot hear you.
Unmute yourself, please.
Yeah. So what I can see is the proximal phalanx physis has been spared, but the middle phalanx physis is grossly disrupted, and there is a separation of entire middle phalanx at physis level is what I can see. And along with that, I can see a head of proximal phalanx transverse fracture or little rotated fracture. That is what I can see on X-ray.
Yeah, correct. And there is a dislocation also.
Yeah, dislocation and PIP.
Yeah, correct. So this is a very unique case. So so what else you see with the epiphysis? You see anything with the epiphysis here, or it is just an epiphysis? Which is
I think it is displaced on the dorsal aspect, or is it displaced on the X-ray?
Yeah, it is displaced on the dorsal aspect. So the epiphysis ideally should be here, but it is gone dorsally. And another thing, what you can see is that there is a thin bony shadow we can see here. So basically, it has not gone through the epiphysis. It is not a physial separation per se, but there is a thin bony injury also here. So this is a bony injury at the fascial level with a condylar fracture here and dislocation. So anyone can just comment how can you manage this injury, Dr. Rohan?
Bipin, I've not seen this injury.
No, I'm just asking you what you will do. You will try close reduction. It is come immediately in your clinic, and what you'll do?
Okay.
Close reduction, or you'll explain the parents that no, this requires surgery. So parents will ask you what open, closed, how will you approach this child, or will you get any investigations done? Your approach, I want to know.
Okay, so I won't get any further investigations. I would discuss open reduction and fixation for this, because there are too many. I see too many pieces at too many places where they should not be. So I would never be able to get a close reduction in this. Okay.
Correct.
I would do probably I would explain open reduction and fixation.
So will you try a close reduction one shot in the operating room?
I don't have that much courage to try close reduction in this particular X-ray.
Okay.
I might end up causing more damage if I try and reduce this.
So the problem with this injury is that I have managed this injury, and there are a lot of things I'll show you later on. But the problem with this injury is any orthopedic surgeon will think, or any one of us will think, that we will try and get it closed and pull it once in the clinic. Might. Even I had this thought in my mind, but looking at the X-ray, as you said, I thought that better to get it under anesthesia because of the pain, vasovagal. Children get this vasovagal symptom. Anything, close reduction also if you do for plaster, forearm, that time also we do a small short sedation or something like that. So I just want to know that you take this patient in the operating room, explain the parents about open reduction, but I had given it a try of close reduction, one shot I tried to use a K-wire to put that in. However, it was not possible. So anything like you want to discuss, that what can happen in this case if you try close reduction? I had tried close reduction only one shot. I tried it, but then it was not possible. So without wasting any time, I'll go ahead with the presentation. So this is a very unique type of injury. It is a variant of a dorsally displaced epiphyseal dislocation of the middle phalanx. So it is called as a jockey type of dislocation because on the lateral X-ray you see that the epiphysis is lying on the proximal interphalangeal joint. It looks like a horse jockey, like a jockey is riding a horse. So this has been described by a Japanese surgeon in 1996. His name is Hashizume. He's described it, but his injury was significantly late. Means but recognition of this injury takes long time. So patients come to you very late, maybe after a month or something. But this patient had come to us very early. So this is a type of injury which is here. So this type of dislocations, there are 2-3 papers on this, but not similar type, but the irreducible. So this joint, it is a PIP joint dislocation. So Whipple, Skeen, Hashizume and Jones have described this type of PIP joint dislocation in children. There are very few reports which really tell us about PIP joint dislocation in children, out of which these 4 have already, out of which Whipple has 2 cases, Kenny has around 1 case, Hashizume has 1 case, and Jones has 1 case. So this is very, very less of a literature here for PIP joint irreducible dislocations. And now we go ahead with the case. So this is the photograph from Hashizume's paper, who has described this injury for the first time in 1996. So according to him, it is a Salter-Hallis type 1. That means there is a the injury is through the epiphyseal plate. So it is a physeal slip in his case. So it is Salter-Hallis type 1, and it is dorsally displaced, and he has the epiphysis is lying on the dorsum, as you can see. But this injury he had recognized a month later. So after which he had operated it, put the epiphysis inside, but then they don't have any follow-up of this case. So what is the variation in my case is this case is that this is a Salter-Hallis type 2, because as you compare it with the other case. So there is a small flake of bone here in the case which I am presenting. However, in this case, there is no flake of bone. So it goes in Salter-Harris type 2. And along with it, there is a condylar fracture along with dislocation. So this is the variation of this case. So this is another very unique case which I am showing. So this is a mechanism of action which I have described for this case. Like if the two forces, these are the two desks, when the child's finger gets entrapped in it, and when he tries to pull the finger, the epiphysis goes because of the central slip, action of the central slip, the epiphysis slips and goes out, and finally it's the middle phalanx snaps back into its original position. However, because of the force, there is a fracture of the proximal phalanx condyle also, and there is a collateral ligament rupture, as you can see here. So I tried close reduction, as I had spoke before. However, it was not possible. So what were the tips? So as soon as you open it dorsally, and what I found was it was buttonholing through the extensor tendon. So this is the extensor tendon on both sides, and the physis was coming out. So now how to recognize that which part is what? Because as soon as you go in, you are confused that what is which part is dorsal, which is volar. So the idea here is that as soon as you see the epiphysis and you release it, you'll see the central slip attaching somewhere on the epiphysis. So the attachment of the central slip is the recognition that you will find that it is a dorsal part of the epiphysis, and so that is an indicator that which part is where. And then you can put the epiphysis in by slight flexion, traction. And after that, hello?
Yeah, Bipin, you have 1 minute. Huh?
Yeah. So after that, what we did was we close reduced and put sutures. There were no K-wires put, and it was aligned completely. Fracture healed in 3 months. There was full passive flexion, extension. There was active extension was not possible. However, at 1 year, what I saw was there was a restriction in extension. That was because of the collapse of the condyle. So this is also described that the collaterals get blood supply from the condyle get blood supply from the collateral and the dorsal capsule, because of which at 1 year AVN has happened and there is restricted joint movement. So I just wanted to this case I have put forth because every condylar fracture, even in adults, you should preserve the collateral ligaments and the dorsal capsule. Don't cut collaterals and the capsule together because it will hamper the blood supply and cause AVN of the condyle. And AVN will lead to condylar collapse and gradual deterioration of the movement. So this is a paper which I had already reported in JBJS last year. And so another injury, it is a similar type of injury which I did 3 weeks back. Similar type of injury, type 2 Salter-Harris. The physis is going behind, but this is a precursor of the injury which I had shown. It is not come outside. So as you can see here, there is a depression here that the distal part of the middle phalanx is gone down, and this is the epiphysis here, and the central slip is attached here. So in this case, we reduced it and managed and fixed it with KY. So take home points: epiphyseal injuries of middle phalanx are very PIP joint in children are complex injuries. Open reduction is an internal fixation must for these cases. When accompanied by proximal phalanx condyle fracture, chances of AVN of the condyle are very high. Thank you.
Yeah. Nice case, Bipin. Please stop sharing your screen.
Yes.
And so do you feel that we should explain the parents that, these injuries are going to cause facial arrest or something like that? Or
yeah. So I think that
okay. So I would like to go with my now third case in the discussion, and I would like to ask Dr. Rohan that this young gentleman, had a left little finger cricket ball injury. Okay, and yes, Rohan, may I request your approach to solve this case?
Okay, I'm assuming somebody has put some tapes around the fingers. So first remove the tapes and get a good dead lateral X-ray of the small finger.
Yeah, agree.
Okay.
So again, the message here for all the listeners, whenever you are seeing a phalangeal fractures, please take a proper dead lateral X-ray. That's a very important message. Never take a hand AP oblique X-ray for any phalangeal fractures. May I request Samrat, Dr. Samrat, your approach on managing such patients? How do you treat them? Can you tell me in briefly? Tell us. Will you conserve this non-operatively treat? Please keep yourself unmute so that we do not waste much time. Dr. Amit, are you online?
Yes.
Yeah, please tell me your approach of managing this case.
See, this patient is having proximal interphalangeal joint fracture dislocation. In this cases, we have to see how much percentage of articular surface is involved. Whether it is less than 30%, up to 50%, or more than 50%. Here it is. It looks like it is around 30%. So first, in such cases, I will try to reduce this case, reduce the joint, and see in 30-degree flexion whether it is stable or not. If it is stable in 30-degree flexion, then I will just put a dorsal blocking splint, or we can put dorsal blocking K-wire.
Okay. And if it is unstable at 30-degree, what would be your approach?
Yeah, if the case is fresh, then in such cases we can go for a dynamic external fixator like a Suzuki frame, where we can reduce the joint and reduce the fracture also. Yeah.
Is Dr. Samrat available? Okay.
Sorry, Parag.
So Dr. Samrat, do you agree with Dr. Amit, or you consider open reduction and internal fixation if you are not satisfied with the reduction at 30-degree, or you are requiring more than 30-degree flexion?
Yeah, I think that if this is a fresh fracture, once we reduce it, even if the reduction comes at 50-degree of flexion, we can manage that for about 2 weeks and then reduce the flexion.
Okay.
So my approach would be to reduce it, put an extension blocking wire, and manage it.
Yeah.
So this is very nice reduction.
Yeah. So as Dr. Amit and Samrat said, in PIP joint acute injuries, whenever you are seeing a molar fragment, there are two things that everybody should look for: is the size of the fragment and reduction at what degree of flexion of PIP joint the fragment is getting reduced. So usually these injuries are to be treated in the operation theater under digital block and under Shyam. You can on OPD basis also check to discuss the treatment options with the patient. And this was a very stable reduction at 30-degree, and this is how we put a dorsal block wire. And usually I keep the wire for minimum 3 weeks. Anyone keeps this wire for more than 3 weeks, or any other protocol to treat these fractures? Dr. Bipin, what is the duration of wire that you keep in this case?
So I will keep the wire for around 2 to 3 weeks and ask the patient to flex it inside the wire so that he doesn't have any problem in flexion, and maintain the flexion the attitude 30-degree, and flexion deformity we can correct later on by stretching. So another option in this case is that we can use a Suzuki frame.
Correct.
For this.
Fine. So Dr. Rohan, sorry, this is a 1.5 mm wire. It is really too thick wire. But what is the ideal size of wire we should consider for a dorsal block pinning? Any idea, Dr. Rohan?
1.2 should be enough.
Okay.
Provided the patient doesn't. So you have to tell the patient that don't try to forcefully extend it. Try and flex it as much as you can and come up to extension gently.
Have you all came across any time about the extension lag whenever we are treating this fracture by Dr. Kiran while putting a dorsal block? Have you seen extensor lag, and how do you correct that if you have encountered?
Having an extension lag in a PIP fracture dislocation is a part and parcel of the treatment plan. Because of extensor tendon handling, by any means, whether you conserve or treat it operatively with extension block or Suzuki frame, extension lag is bound to happen. But as Dr. Bipin mentioned, getting a flexion for a useful grip is important. Once a flexion is achieved, we can treat this extension lag by giving a spring splint. That's nomenclature-wise, it's a Kepner splint. It's a dynamic one where patient can do extension as well as the flexion in both.
Dr. Rohan, can you please start sharing your screen to present your case?
I want to add one more thing. That we have to ask the patient to actively and passively mobilize his DIP joint in these cases. Otherwise, they get stiff.
So apart from Suzuki frame, is there any method of, and apart from open reduction, that is not my discussion. Have you all seen your seniors or your own methods of fixing? Anybody look who can do static distraction or a static fixator for some period apart from dorsal block? Any other method of treatment in such cases?
Yeah, I have done static distractor and used this, but that was for more comminuted fractures. For such fracture, extension block pinning is the ideal one. Like it works well.
Fine. Yes, Rohan, can you please discuss your case?
Can you hear me?
Yeah.
Yes.
So this is we did with Dr. Pankaj Ahire. So I would like to thank him as well. He's our mentor and colleague. So this is an 18-year-old boy having a direct trauma. It's a closed injury to the second and a third metacarpal. Samrat, we'll focus on the second metacarpal. Would you want to do any further investigations, or what would be the line of management for the second metacarpal?
Yeah, I would like to get a dead lateral view and a slightly supinated view to see further about the second metacarpal.
Okay. Suppose there is a rotational malalignment. How would you go ahead with managing the second metacarpal?
Yeah, if there's a rotational malalignment, it is best to there seems to be a long spiral oblique fracture. It's best to put 3 screws, 1.5 or 2 mm. 1.5 would be okay, but otherwise 2 mm screws would be ideal. There may be a butterfly fragment, but if that is there, then we have to keep a plate ready.
Okay. So for the second metacarpal, there was no butterfly. What we did exactly what you did. We did an open reduction and multiple screw fixation. Amit?
Yeah, yes.
Third metacarpal. Now, third metacarpal did have a butterfly along with the distal fragment. Would you still go ahead with screws, or would you prefer a plate?
Since it is a long spiral oblique type of fracture, I think interfrac screw fixation is better. But sometimes, as Samrat said, if it is not stable, then we can add with the plate from dorsal side.
Okay, so both of them said the right thing. So we did a dorsal approach. We did the incision in between the two metacarpal. We did an open reduction and plating along with an interfrac screw for the third metacarpal. And we did actually 4 screws for the second metacarpal. So there would be a 4th screw in the post-op pictures. Okay, this is a very standard technique. I'm sure everybody would do it. I have presented this case because we landed up with some complication on a day 5 X-ray. All right. So the first complication was on the day 5. If you see the second metacarpal, the fracture site has opened up in the distal aspect. Parag, would you tell me why this would have happened?
So did you start early mobilization or something like that? Or did you have a good purchase because I see a locking screw in the distal, only one locking screw in the distal fragment.
Okay, so it was a long spiral oblique fracture for the second metacarpal. We had all 4 screws having good purchases.
Okay.
We started early mobilization on about day 2 or day 3 as pain tolerated.
Yes,
Rohan?
Yes, Amit.
I think in such cases of long spiral oblique, we should put screws perpendicular to that, so that screws will not come in one line. It will be in 3 different planes.
Okay.
We will get good reduction and rigid fixation.
But that is how it is possible to do that in the plate. That means you are talking about interfrac screw, right?
Yes.
So no, right now I'm talking only of the complication of the second metacarpal. I have not yet reached the third metacarpal.
Is it because of the wrist extensor working because of your early mobilization? Is that because the ECRB is attached at the base of third?
Okay.
I'm just thinking aloud.
Okay. So we'll come back to the second metacarpal in a bit. I'll tell you why this would have happened. In regards to the third metacarpal, why do you think the plate broke? Is Kiran around?
I'm around.
Yes.
This is the 5th day, mind you. This is the 5th day post-op. So the plate broke maybe on the 5th day. Kiran?
The wrist was immobilized, right? As in, I can see the plaster support.
Yeah.
The dorsum.
Yeah.
Okay. This was a titanium combi hole locking plate.
Yeah. So this was a proper plate, not local made.
Okay.
Was it pre-bent a lot?
Exactly.
Yeah.
As Dr. Samrat mentioned, was it contoured? And I can see in this plane the screw probably going out of the cortex.
Right. So 2 things we learned in regards to this. One, for the third metacarpal, we tried to contour the plate along the contour of the third metacarpal, and that actually can reduce the strength of the plate. These are, mind you, these are 2 millimeter plates. The second thing, yes, the screw we thought was going into the base of the third metacarpal. Probably it was going into the intermetacarpal area. And the third thing was, this young guy started doing aggressive mobilization. So there was some movement that was transferred at the CMC joint. So mind you, a micro movement at the CMC joint can also lead to this kind of complication. Same goes probably for the second metacarpal, because this gentleman started mobilizing early. However, we ended up having a good result at 3 months. He has a fairly full range of movement. Everything healed the way it was. For me, the take-home points were, try and get as stable fixation as possible. Like Amit said, get the screws in multiple planes, ensure that they're exiting out of the opposite cortex, so you have a bicortical hold. Make sure that there are adequate screws. 1 millimeter screws or 1.3 millimeter screws can be spaced out nicely. Be careful when you mobilize these young people. When they mobilize very hard, when they try and make a fist, make sure that they're not gripping they're not doing any grip. They're just doing gentle range of movement. And if at any point of time you feel the fixation is failing, try and protect it. We can always achieve movement later, but it's important to get the union first. Thank you.
Yeah, excellent case, Rohan. So you were mentioning about contouring the plate. Did you contour this plate?
Yeah, so we bent it so that it doesn't, so the base of the third metacarpal is a little curved and the plate was sticking out straight. So we thought,
do you recommend to do that in next cases? Because
no, after that I've not bent it.
Rohan?
Yeah.
Yes, Bipin?
Yes.
Yeah, I see this thing about gripping is a very important what you said. And what I feel, the interfrag screws, you had put only one interfrag screw, correct?
No, you're talking about the second or the third metacarpal?
Third metacarpal.
So, okay.
With the plate.
No, okay. So there was one interfrag screw which was holding the butterfly to the proximal fragment. And there were 2 or 3 screws distally and 3 screws in the proximal fragment. It was a very comminuted fracture to begin with, the third metacarpal.
No, it is a difficult case. Then another thing is that when you go in, you get very confused. Where is the base?
Okay.
On the Shyam also, it is very difficult to realize because Shyam images are very dicey. In these type of cases, we don't know where is the base. So the screw which you put outside, I agree that it is very difficult to put that screw because sometimes it might go out. We don't know because the Shyam images also shows us that it is inside. So this is a really tough type of.
Dr. Kiran.
Okay, Kiran. Yeah.
As Parag mentioned, ECRB inserts on the third metacarpal base. But any tips to spare that attachment? And my second question is, now with this complication and still salvaging well, do you consider implant removal, and at what point?
The ECRB tendon, so there was enough space distal to the ECRB insertion to put the basal screw, proximal screws, and we didn't have to elevate it. And I would not recommend to elevate the ECRB insertion. It's an important tendon. There is no implant prominence for this gentleman. He never complained of the implant, actually, even the base or the broken plate. And he's doing very well. He started playing what he was playing. So I would
last question. Does patient know about implant failure?
Day 1. Since day 5 we knew, and I told the parents, I showed the parents and the patient, this is what has happened, because X-rays can't lie.
Yeah. So very important message. Very important message to all the listeners and even us, that in hand, it is better that we discuss that we can, even if there is an implant failure, there is a way to manage such cases and to can get a good result. Okay, and they managed it by just protecting the hand in a splint or a slab, and that was a good outcome. Yes, thanks, Rohan. Samrat, can you please start discussing your case?
Sure. So we'll be discussing two cases of fractured trapezium. And I thank all my seniors. I thank Parag. The slide shows that apart from being a very good hand surgeon, he has got a lot of determination and hard work. And as you see in this marathon and summit. So these are two cases, both of trapezium fracture. And there is a fracture dislocation of the first carpal metacarpal joint. And though as reported, the incidence is 1 to 5% of all carpal fractures, I understand that there must be a set of trapezium fractures which are getting unnoticed or they are not reported, and that's one reason that we are presenting this, to show what are the results of such fractures. So this is another study which shows that it's about 8% of the fractures. And this is the longest study where there were 11 fractures described, and out of which, apart from isolated trapezium fractures, it is associated with Bennett's fractures and distal radius fractures and other high injury cases. Only 2 points to talk about. One is that there is a ridge on the volar aspect and a groove for the flexor carpi radialis on the volar aspect, and the blood supply is huge from the dorsal aspect, and radial artery is there on the dorsal aspect of this bone. So if you can appreciate that patient who may just have a fall and may neglect it for 3 to 5 days, and then when they come, then the pain can be attributed to first CMC joint base. It may be attributed to scaphoid, which is the greatest mimicker, or actually, if we suspect, then it can be you will not miss a trapezium fracture. So that is the ridge. And the patient can have pain on the volar aspect or also on the radial dorsal aspect. These are the two most important views. We all know about this. Yeah, so intraop, a lateral radiograph with 10 to 30 degrees of supination gives a very good view of trapezium, and that helps in the fixation. So this is the Walter classification, and our fractures were of somewhat like this. But if the fractures are a vertical fractures, very straightforward, then probably the fixation can be a different way. Because they are comminuted fractures, they are associated with dislocation of the first carpal metacarpal joint. So this is the first case, 28-year-old male. He has a closed comminuted fracture of the trapezium with a dislocation, and he had a fall on the outstretched hand. Diagnosis 15 days post injury. And that's the second case. He's a 20-year-old boy, and he came with a similar fracture with a more comminuted fracture here, and diagnosis and treatment was within a week. So now I want to ask everyone, what are your experiences and what would you prefer, whether to fix them or to conserve them? Do you want any other investigation which should be done? And how would we discuss this with the parents? Because the arthritis of this joint is inevitable with the intra-articular injury which has happened. Yes, Parag, can we start with you?
Yeah. So apart from a proper X-ray, as you showed about wrist APPA lateral and Robertson view, I would recommend, if such a comminution in the fragment, then I would like to get the CT done for that trapezium, and I would like to discuss whether these fractures are fixable or not fixable, and let them heal in the position they should heal. And then later on, if there is arthritis sets in, then should we just do simple trapeziectomy and ligament reconstruction? So, but a 20-year-old person, he definitely, and it is the, ultimately it's a thumb that is going to be painful in future. My first approach will be CT, to consider a CT scan and try to save trapezium and fix it. But it has to be fixable, because this second case, I think it is definitely very challenging.
Yeah, Kiran, any thoughts?
Agree with Parag.
Okay. So, I'll move on?
Yes, please move on.
Yeah. If there is an articular displacement of more than 2 millimeter, or there is a carpometacarpal subluxation, then we advocate open reduction and fixation. So that's a literature support to it. So it can be by wire, it can be by screw. If there's a very straight vertical fracture, coronal or a sagittal plane, then of course a screw can be used, open, close, whatever, with or without ligament reconstruction in some cases, and a transmetacarpal wire can be also put. So the approach is straightforward Wagner's approach between the thenar glamorous skin and the dorsal skin. One thing I want to put here is that we have to be sure of the superficial branch of radial nerve and the radial artery injury. So in the case 1, we did an open reduction because it was not possible to reduce it. It was 15 days old, and we did a bone graft here. So it was reduced, it was fixed with K-wire after bone grafting, and then as an insurance, I put an external fixator here. And the POP slab was for 2 months, like we do for a scaphoid, and the rehab was up to 6 months. So the wires were removed after about 3 months. This is a 6 years follow. Patient has got some pain while lifting heavy objects, like something when he has to serve rice or something, or using holding his child with one hand. Otherwise, he is comfortable. If you look at the Kaplanji score for the opposition, he has got about the best which we can get. This scar is of the radius area where the bone graft was taken. So that's the Kaplanji score. In the second case, which was more comminuted, and we were ready with, to get whatever we can get and then do a trapezium excision later on. That's a CT scan, which was done. It was done for both the cases, but I put it for the second case. And I want to add is that even in Nagpur, we can get a 3D reconstructed model with this CT scan at cost as less as 600 to 800. So if there is a confusion, we can always get a CT scan based 3D model. So and comparative X-ray at times makes helps the patient to do a decision, as it is different, but we could reduce this closed. And as I said, different views are important. A supinated view in 10 to 30 degree also helps in putting the K-wires and placement. So first, I secured the first carpometacarpal joint with a wire across the first to second metacarpal. And then I fixed the trapezium here with K-wires. And again, the rehab was for 2 months immobilization, and then a long period of rehab was done. Patient has got no pain at the end of 4 months, and he is doing well. This is his 4-month X-ray. So to end with that, some pain will be there, some decrease in the movement will be there. There will be definitely X-ray pictures of the arthritic changes seen, but most of the patients will not complain of the arthritic pain as we see in a baser joint arthritis related to job or to age or inflammatory arthritis. Any thoughts further?
Yeah. No, Samrat, excellent cases. The message here to all the orthopedic surgeons and viewers that in the carpus, yes, we understand the scaphoid is the most easily fixable bone. I mean, technically, yes, it is. We do have more experience, but please consider trapezium is the important bone which bridges the gap between the thumb and scaphoid, and with the trapezoid. So we have to consider proper diagnosis, proper fragment specific anatomy by considering CT, and it is possible to fix. So as Dr. Samrat did, we can this usually. May I ask Dr. Samrat? Meanwhile, Dr. Amit, can you please share your screen? And Samrat, stop sharing your screen. So I would like to ask a question to Dr. Samrat. What would be your last limit to operate such cases? These are both acute cases, right? If they present to you at 2 months, will your plan of treatment remain same?
Yeah, my plan of treatment will remain the same since we may still be able to reconstruct the articular surface, and that will definitely decrease the ultimate degree of arthritis which the patient is going to have.
Okay. So what is your last cutoff limit if we want to hear? Like any literature to support that, or as per your experience, till what months you will consider fixing trapezium? Because they may come as a neglected injuries.
Yeah. I don't have any experience. It will be more of in that case, we'll take a consent with the patient and do an open reduction internal fixation. And when we open, we'll see the state of cartilage and then decide on table what has to be done. That will be right.
Yeah, thanks. Any Rohan or any other faculty has any experience in managing chronic cases? No. Fine. No. Yeah. So Dr. Amit, can we start with your case discussion?
Yeah, yes. Can you see my slide?
Yes, very well.
Okay. Yes, thank you, Parag, for giving this opportunity. So we'll straight away start with the case. This 23-year-old student had fall and outstretched hand. He fell down from two-wheeler and he presented to us with scaphoid non-union since 5 months. So first, I would like to ask Samrat, how will you read this X-ray, particularly lateral X-ray? Can you see? Yeah, is Samrat there?
Yes. So the lateral view has been taken very appropriately on the left wrist. What we see is that the lunate has tilted on the dorsal aspect, and the angle between the scaphoid and lunate, the scaphoid lunate angle seems to be decreased here. So that's one thing which I think, and that is suggested if we collaborate with the AP view, the PA view, then probably this is because of the collapse of the scaphoid.
Yes.
And the break in the link between the scaphoid and the lunate.
Yes, very rightly said, Samrat. So here lunate is extended and this is a DC deformity. So in such cases of waist non-union of scaphoid, when there is DC deformity, Bipin, do you need any other investigation in such cases to go to proceed further?
So first of all, these are only 2 X-rays. I would like to take other remaining X-rays also. So AP lateral, scaphoid view, prone oblique and supine oblique. So after this X-rays, so mostly it is a DC. So I would like to go ahead with a CT scan because DC is mostly best seen on CT scan.
Yeah.
And non-Indian. Yeah.
So is there any particular?
What is the duration of non-union, Dr. Amit?
5 months.
5 months.
5 months.
So these are the CT scan views, and we can see that intrascaphoid angle is less than 45 degree. So the most important question is how to take CT scan. So according to this paper, sections are made along the long axis of the scaphoid at 1.5 mm interval, beginning from radial to ulnar side, is the ideal way to take CT scan in such cases. So on seeing the CT scan X-ray, the picture is very clear. This patient is having scaphoid non-union with humpback deformity. So my question is, do we need to correct the humpback deformity? So yes, we need to correct it, because if there is humpback deformity, then scaphoid will not unite, number one. And second, it will alter the wrist kinematics. So according to this paper of Amadio, when the lateral intrascaphoid angle is greater than 45 degree, then in such cases, satisfactory outcome is seen only in 27% of the cases. And there are chances of post-traumatic arthritis. So these are the reasons we should correct the humpback deformity. So is Rohan there? Rohan, how will you correct the humpback deformity?
So you're asking me the management?
So this patient, we have diagnosed that this patient is having humpback deformity, and now we need to proceed further, and we need to reduce the deformity.
Okay, in my hands, an open reduction, correcting the non-union, like clearing up the non-union and filling it up with something would be the only way I can correct the humpback deformity.
Oh yes. So basically in such cases, this is a very nice diagram. Here we can see that there is wedge-shaped defect on the volar side. So we need to put a wedge-shaped graft over there. So for doing reduction, there is one Tomeno's maneuver in which first we flex the wrist, and it flexes the actually extended lunate. Then we put radio lunate wire and then slowly extend the wrist. So this is as Rohan rightly said, this we do during the surgery. So it will extend open up the gap on the volar side of the scaphoid, and as if right now we have seen that picture, it will create a wedge-shaped graft, a wedge-shaped gap on the volar side. So now we have to put wedge-shaped graft over there. So these are the intraoperative pictures. And this with left hand side we can see the gap, and right hand side that tricortical wedge-shaped graft we have put over there, and it was fixed with headless compression screw. And this patient, a scaphoid is nicely united. This is 7-month follow-up, and he has achieved good range of movement also.
So Amit, do you use some burr or for cleaning up this non-union site, a dental burr or something, or it's not required? You use a curette?
Generally what I do, I put two 1.25 wires perpendicular to both the fragments of the scaphoid, proximal and distal fragment, and just to have a hold on both the fragments. Then with the help of fine nibbler, I just do a cavity in both the fragments. I don't use burr.
So for humpback deformity, your choice of bone graft is iliac crest, or may I know what are the other choices of bone graft, and how do you decide? Do you use the bone graft iliac crest in all cases?
Yes, actually, in such cases of humpback deformity, the gap is a very big gap, and we need to maintain the length of the scaphoid. To maintain that length, we need some cortical type graft. So that's why iliac crest is the preferred site. Yes. When there is no humpback deformity, we can go for cancellous chips from the lower end of radius or iliac crest region.
So do you want to give one message to all the listeners that humpback deformity is better clarified or diagnosed on CT or on lateral view of X-ray? What would be
Yeah. So the most important take-home message I want to give: first, see lateral X-ray clearly.
Okay.
If you are suspecting that there is some dizzy deformity, then in such cases, keep in mind that there may be some humpback deformity and go for CT scan. Okay, if both the investigations suggest that there is humpback deformity, then in that cases, as you rightly said right now, that we need to think on which graft. So we have to go for cortical graft. It's basically a combination of cortico-cancellous graft, we can say, but only cancellous graft will not work.
Yeah.
So this is how we can manage these cases.
Amit.
Just Samrat.
Yeah, one technical tip if you can share. So now we have got a area which is the scaphoid is completely open, and what I want to ask is that you can put most of the you can put whatever size of graft you can you have to put. It's like an open book, so it will just keep on opening. How to see the end point, because at times the dorsal cortex, if this is a volar approach, that's what we are doing. So the dorsal cortex is also weak, so it will just keep on opening. What are the references? What do you think should be used?
Yeah, generally, what I do, I just take a small towel and do 30-degree wrist extension, not more than that. Okay, and when you do this reduction maneuver and 30-degree extension of the wrist, then the scaphoid non-union side will open up. Okay, so then you can nicely see how much is the gap over there, and after curate, just don't extend it more than that. Then the gap will go on increasing. So then you will not come to know how much graft we have to put.
Dr. Amit, can you stop sharing the screen?
Yes.
And so that we will continue the discussion.
Yeah.
So see, this is the non-union. So Dr. Kiran, please share your screen. Meanwhile, I would like to ask all of you that this is a 5-month-old non-union scaphoid. And do you prefer MRI or do you prefer CT scan? How do you decide? In one liner, like everybody can answer. To start with Rohan, yeah.
I prefer an MRI.
Okay.
I would like to see the vascularity. It doesn't change my line of management. I would still go for what Amit said, a tricortical iliac raised bone graft. But I would like to prove or disprove the presence of vascularity or avascularity, maybe for medical reasons.
Fine. And last comment from Bipin.
Yeah. So I feel that MRI is okay, but at 5 months at waist fracture, MRI will not mostly show vascular deficit. So MRI with CT cuts, you can advise MRI with CT cuts so that both things are addressed very well.
So in CT cut also, if you ask them to take a lateral or
correct
sagittal, Kiran, please make your screen full screen. Amit, you want to say something?
Yes, that MRI should be contrast enhanced MRI. But according to literature, contrast enhanced MRI also fail in 23% of the cases.
Okay.
But that is the best what we can do for a preliminary understanding of the vascularity.
Yeah. Kiran, we are not able to. Yes.
Visible now?
Yes.
Make a full screen.
Yeah. Can see the screen now?
Not full screen, Kiran. So you stop sharing the screen and open your screen first. Your presentation, you keep it open and minimize it and then share your screen.
Am I?
No, but you continue now, Kiran. We are able to see your not full screen, but please continue.
Yeah, so thanks OrthoTV and Young Surgeons Forum. Parag, thanks for inviting me. I'm presenting a case of a fracture of the lower end of the radius. Now the question is whether to approach volar or dorsal. Young guy, 36, right-handed, he's a finance executive, fall on outstretched hand. with a wrist effusion on the dorsum and painful range of motion.
Yeah, Kiran, we are not seeing your progression. I mean, your slides that we are not seeing. Huh? Yes, now we are seeing.
You seeing now?
Yes, yes.
Okay. So now, as you can see, the wrist effusion on the dorsum. The further proximal to it is patient's birthmark. So I also got initially confused, but this is the effusion on the dorsum, and this is the injury film what we got, the AP and the lateral views. Conventionally, it is taken as PA. Now we can see the fracture line at the intra-articular level, and there is a die punch kind of a fragment which you can see, and there is an intra-articular depression with a dorsal rim fracture here, as you can see it on the injury film. So to start with, Parag, as in your inputs, how will you approach any further imaging you will like to have, or you'll decide your plan of management based on these X-rays?
So what I read is there is an intra-articular fracture, and on the AP, the fracture line is discontinuity is noted more on the lunate side of the fragment, but on the lateral there is a dorsal comminution or dorsal fragment is seen.
Yes. Yes.
So there are first of all under hematoma block a traction X-ray, and if it is a very painful and if patient does not allow, then yes, CT scan would definitely help me to plan my management.
Yes. So rightly on the same ground, I asked for a CT scan, and these are the CT images in a axial and the coronal plane, where you can see the fracture line more on the dorsal rim, the intra-articular component here, and the dorsal rim, where you can see the volar cortex being intact and the comminution being on the dorsum. Now, these are further images where you can see the dorsum. Now, with this imaging, I opted for dorsal approach. Now, pros and cons are direct visualization on fracture reduction is easy. You can buttress it against the dorsal collapse, hence the biomechanically it's a superior construct. And lower and more anatomical profile plates have reduced the chances of tendon irritation. These are the two types of plates which can use theoretically. Indications being, now this is the classical indication in this case, dorsal die punch and comminution. We have seen the CT scan, and this is the post-operative. I went through the third and fourth extensor compartments, and we have addressed to the dorsal intra-articular comminution with elevation of the fragments. These are Synthesis 2.4 mm low profile titanium plates with locking mode. This is the post-operative, immediate post-operative within the cast. Now, one more important point here to take a proper X-ray. If you take a 10 degree PA view, you will see the plate hitting onto the dorsal rim, and that's why you will feel that plate is impinging onto the dorsal rim, but it is sitting exactly on the dorsal rim, as you can see it on the lateral X-ray here. He went on to do his rehab properly. This is the X-rays post-op. Now, 3 months down the line, fracture healing well. Physiotherapist provided us with the sequential range of motion, which is gradually improved at all ranges, flexion, extension, and the deviations. This is the X-ray. We can see it at 6 months, where the dorsal rim is well seen and the tilt being restored well. The implant is positioned fine. At this point, since patient was quite apprehensive and high demand, he wanted the implant to be out. And as we can see, the fracture was healed well. He opted for implant removal. This was the range prior to the implant removal. And this is the post-implant removal, where you can see the articular line being restored well on the PA view, and the lateral view, the rim being restored well. This is the around week-old. So his post-operative rehab continues. He's getting good dorsiflexion. Volar flexion is coming back. And just to summarize the complications, extensor tendon irritation or rupture is very, very common, but with low profile plates, it's getting reduced. The most common reason being screw head or the plate prominence. We can prevent this by local soft tissue interposition flaps. Periosteum of the third and fourth extensor compartment to be elevated well, and that covers the plate post fixation. That gives no incidence of tenosynovitis or tendon adhesions or ruptures, which is explained in this article by Szabo et al. And so implant removal is to be considered in such cases only if, now, two reasons: if patient has tendon irritation or rupture, which can be minimized, as I said, or patient demands for implant removal, and the ideal time for that is around, say, 6 to 9 months in a dorsal plating for the fracture of distal disc. I thank everyone for patient listening.
Thank you, Kiran. Can you please stop sharing your screen and we will take the questions?
Yep.
Okay. I will. Any faculty has any question, or they would have done their case in a different manner?
Kiran,
Yeah.
have you ever found the need to put a bone graft when you elevate the die punch?
No, I haven't found any need to, because that's as you elevate, there is a very tiny void which the screws support that as a raft configuration. So there doesn't remain, and then the cancellous bone heals by physiologically the crimping substitution method. So there is no need of putting a bone graft actually.
And
I won't. Sorry, can I add? When you go for these die punch fractures, especially for the younger crowd, I would always keep some artificial bone graft in a solid manner, not the powdered manner, ready. Also taking a consent for a localized autogenous bone graft, like from the olecranon, ready, just in case you have a very thin sliver of these die punches. And when you lift it up, sometimes you might have a significant deficit. So the bone graft itself will act like a good support, and then you can use the screws like the way you said. So just keep everything ready. That's what I would suggest.
may I know any, apart from like you are practicing in a city, and apart from a dorsal plate, is there any method we can use to fix this fracture, Dr. Kiran and Dr. Samrat?
So if as in young demanding individual like this, where open reduction interfixation is not possible, then intrafocal pinning after close reduction is one important mode of management which one should be keeping in mind. Acronym wise, Kapanji, who has devised this method. So that can be one mode of management.
Okay.
I would just suggest that even as SS plate, which is cheaper, should be used, because these are really difficult fractures to deal with, and we have the option of removing the plate sooner. But I would still prefer using a plate.
Okay. So thanks, Dr. Kiran. Is my screen visible?
Yes.
Yes.
Yeah, I would like to discuss the management of this case with Dr. Bipin's input. 34-year-old male and acute fracture. He presented to us on 6th day of injury. It's a closed fracture. May I know your line of approach to treat this?
So this is a first metacarpal base fracture with some comminuted, like some fracture line going through the shaft also. It's not intra-articular. So I would like to open, reduce and fix it with a plate.
Okay. Any faculty has any other suggestion apart from plate, and any other investigation you would like to add?
I would go for an external fixator.
Okay.
I think after opening, if there is some gap, then we need to do bone graft in first surgery.
So the purpose of treating this fracture is to achieve a proper first metacarpal length. This is an extra-articular fracture. That is first purpose. And second is, of course, a union. okay, and to correct the angle at the fracture site, because this will definitely collapse if you don't have absolute stability. So close reduction. So Samrat, you said fixator. You mean to say open reduction and fixator, or close reduction and a fixator?
I meant a close reduction and fixator.
So can you please explain us where will be your pins? I mean, will you do only external fixator, or you will fix with cross K-wires and then fixator? And where will be placement of your pins?
Okay, so patient under necessary anesthesia, we will give a traction and see how these fragments set down. We may have to use some intrafocal K wires to reduce the fracture, and then the same K wires can be used to fix the fragments. Once that is done, probably we would be using two things. One is K wires across the metaphysis, that is, it may start from the head and go to the base of the first metacarpal. That is one. And after that, still the one of the assistant is still giving traction and aiding in the reduction. I'll put an external fixator with one wire through the trapezium and one wire through the neck region of the metacarpal.
Okay. Okay. So you will not go to fix the radial styloid, or your fixator will be in the trapezium and distal part of the first metacarpal, right?
Yeah.
Okay. So yes, Rohan, your inputs.
Yeah, so I would go for an external fixator, a JES fixator with a U frame or a J frame, however you want to call it.
Okay. Okay.
So there'll be 2 pins in the distal part of the first metacarpal. Okay, with those will allow you traction.
Okay.
Then there will be 2 pins in the second metacarpal. Okay.
Okay.
You can connect them with a 1.5 millimeter wire, which is connected. So it will be like this. So
okay.
Two pins. And if you think there is a lot of combination, like Samrat said, you can pass another wire through the fracture site into the proximal fragment into the trapezium. Because there's a lot of combination. So if you're opening it, I think you should be ready with a bone graft just in case.
Okay. So any of you would consider a non-operative treatment for this fracture?
No.
No. Means I think this will collapse into a very short thumb, like a Z deformity.
This is the length is important, and as Rohan said, it will collapse. So we should fix it.
Okay. So this is what I did for this fracture. I mean, first I had open reduction, of course, and then I passed a K wire and maintained that reduction. And of course, it had to go till more distally into the neck. And then I did not do any bone grafting. And then after 3 weeks, I started mobilizing after 3 weeks, I started mobilization, and I removed the K wire on 4th week because it became loose and it just it just came out. So this is the X-ray probably at 3 months and with the solid union. And any comments regarding the fixation?
Good fixation. But the proximal screw of the distal fragment seemed to be in the fracture side. The operative is the only one.
Yeah.
Do you think this is a little flexed? Yes,
it is. So I thought my extensor, I thought the IP, I mean not a metacarpophalangeal joint, there is a little volar subluxation that's what I also thought, and is my central slip or something is irritating. But then his pre-op also X-ray showed similar flexion on the CM. I don't have that image, but
no, Parag. I meant if you see the fracture, the pre-op and the post-op, the alignment of the proximal fragment and a distal fragment
looks same.
It looks the same. So I think it's still flex. Means because thumb has a good arc of range of movement, I think this will be well accommodated by the gentleman.
Oh, point. Yeah. So to prevent that, of course, my plate would have done that, but to prevent that angle, to improve that angle, I had put a wire. But then that came out a little early. But he reasonably, got a good movement.
Yeah.
Yes.
Yeah. So I would like to discuss one case, and after that we will take one more case with Dr. Amit Varhade. that 58-year-old right hand dominant person and a closed injury after fall from chair, and again acute history. Presented acutely. Dr. Kiran, as you discussed about the dorsal plating, may I know your approach to deal with this case?
First of all, traction views, if feasible, the hematoma block, which will guide us about the fracture pattern. If yes,
yeah. So, Doctor, like Amit is like, how will you treat this now? This is the traction view, or you would like to have a CT, or this is sufficient for you?
Yeah, I would like to have CT scan, though it is it looks like extra articular fracture only.
Okay. I have not done the CT scan, but then may I know everyone's one-line answer? What would be your choice if you are considering a plating, a dorsal or a volar, or you would like to assess that in intra, or you don't want to put a plate and put chest? Bipin, any suggestion?
I think Bipin is out.
Okay, fine. Samrat, will you treat this with a plate? Volar. Okay.
Yeah.
Okay.
Yeah, I think volar plate, but keep a very distal fixation plate ready. That would be the only difference.
Yeah.
In your when you start.
Yeah. So
I think.
Yeah. So actually, I had discussed about the considering juxta-articular ream plate for that particular fracture, but then I could get the purchase. This was my fixation, and I had put both the implants ready on table. But then when I looked under 22-degree lateral view, this is how my plate placement is. Any critical comments, or you would have chosen another implant?
Oh, this is fine. Distal ulna fracture also remains stable.
It was very stable.
It remains stable. Okay.
Actually, this was actually a very distal fracture.
Yeah.
In such cases, I think rim plate is perfect choice. But you have done a nice job with this plate in these cases.
I think the fracture was distal on the dorsal side and slightly proximal on the volar side. So the plate could be placed.
Yeah. So yes, Dr. Amit, I would like to stop sharing my screen, and we do have definitely more cases, but now it is already 1 hour 20 minutes. Dr. Amit, please
yes.
Yeah, share your screen.
So we'll take this scaphoid case only for discussion purpose.
Yeah.
This was a short discussion. So this 46-year-old gentleman had a fallen outstretched hand, and he presented with 3-month-old scaphoid non-union. So Kiran, how will you see the X-ray? Yeah, is Kiran there?
One sec, sorry. Sorry, Amit. So, scaphoid view shows non-union of the fracture at the west going into the proximal pole. Proximal pole seems to be sclerotic. This lateral view is a bit oblique, but you can see the fracture line there. Again, to complete the scaphoid X-ray series, the prone oblique, supination oblique, and the AP view is essential. Would like to take MRI in this particular case to see the vascularity of the proximal pole.
So again, the thing which we have discussed, just which MRI and how much is the role of MRI?
So, okay, so shall I?
Yeah, please.
So contrast enhanced MRI basically to see the vascularity of the proximal pole to have a good assessment of the vascularity of the proximal pole. Yeah.
In such, this patient is having a proximal pole non-union of the scaphoid, and as we all know, in such cases, main problem is to see the vascularity of the proximal pole, because a lot of things like union mostly depends on vascularity of the proximal pole. So if we see the current options, one thing is contrast enhanced MRI, which we can do. But according to the literature, 23% cases fail to detect the vascularity of the proximal pole. So Professor Green has shown a very good method of to see the intraoperative punctate bleeding, and which is considered a very specific and sensitive method to see the vascularity of the proximal pole. But here, regarding the treatment options, is Bipin there? Bipin, how will you proceed regarding the management of such cases?
He's not there.
Yeah, Parag, you can take this question.
Yeah, so proximal pole, first of all, I would like to approach dorsally because it's a proximal pole non-union. And many times, even on MRI, I would like to consider MRI to know the proximal pole vascularity. And even if the young gentleman, and 46 is not old, so even if MRI shows a vascular necrosis of proximal pole, I would discuss option of vascularized bone graft versus corticocancellous bone graft and a fixation in this case. But can you share your MRI picture if you have?
Amit,
Yeah,
one question on the X-ray. One question on the X-ray.
Yeah, Samrat.
So is there a fragment which is in the waist region? Is it a separated fragment? It seems to be more sclerosed than the proximal fragment also. Your thoughts? So are we dealing with a huge gap?
Samrat, hello. What did you say?
So Samrat is asking whether there was one fracture at the waist and yeah, Samrat, correct? No, and
Yes,
which was
yes.
yeah.
No. It is due to flexion at the scaphoid, maybe due to that view. So regarding the management of using vascularized bone graft and non-vascularized bone graft. So Samrat, what do you think regarding the use of vascularized bone graft and non-vascularized bone graft in such cases?
Yeah, I would. The whole idea is a lot of bone grafts, vascularized, non-vascularized, don't matter so much as a complete reconstruction of the anatomy of the scaphoid with a lot of cancellous bone and corticocancellous bone in where there is a gap, and then a rigid fixation, maybe with 2 K-wires or one headless compression screw. So I would say a non-vascularized bone graft with lots of bone graft and very, very stable fixation.
Yes, Dr. Kiran.
I may not hesitate in putting one wire from scaphoid to capitate also.
Okay. Dr. Kiran?
Yes, Kiran.
So bone graft is vascularized or non-vascularized, doesn't matter. What matters, as you said, is a punctate bleeding intraoperative and then good stability to the fracture site. Now, whether you use K-wires or a headless compression screw, that is also immaterial. But good packed bone graft with correction of the deformity will lead to union.
Yes. So there was a lot of debate on this issue, and previously there was a misconception that vascularized bone grafting do well and they heal well early and they have very good results. But a lot of papers and literature has now shown that it is vascularized bone grafting has no superiority over non-vascularized bone grafting. But in this case, we did 1-2 ICSRA bone graft. This is in this method we take bone graft from the lower end of radius based on the 1-2 intercompartmental supraretinacular artery, and it was approached from the dorsal side, and this is the pedicle and bone graft, and it was fixed with K-wire, and this is the 9-year follow-up. The scaphoid has united nicely, and he has good range of movement also, and no pain in doing all the activities.
Yeah,
Very nice.
Dr. Amit, excellent result. But can you go back to your post-op X-ray for a while? Yeah. So for the benefit of all of us, you have done one K-wire fixation because you trusted your bone graft. Is that so?
So in this, generally, as Samrat said, my approach is to put rigid fixation by using headless compression screw. But see, or multiple K-wires. But here, the proximal pole size was very, very small.
Yeah.
And screw was out of question. And K-wires, I thought I tried to put another K-wire, but it was not possible. So I thought I may damage the proximal fragment because it was very, very small. So I just...
Yeah. So do you agree that in the lateral view, this K-wire looks more coming out more on the dorsal side and may cause irritation to the extensors, or how did you immobilize and when did you remove this wire?
Yeah, it may cause damage to the extensor tendons. Generally, I keep these K-wires for a long time. Sometimes I may keep subcutaneously means inside the skin.
You bury the wire.
Yeah, bury the...
Okay.
6 months, something like that. Depending on my protocol is to do serial X-rays every month and then decide.
Okay. And lot of learning points in this X-ray also. So I would consider, by not extending the wire away from the scaphoid, because then you definitely cannot mobilize the wrist, because then it will cause irritation to the extensor. Apart from that, I think you have shown your result. So yes, I would request Dr. Rohan to give a
Yeah, sure.
Amit, quickly, since you had opened it from the dorsal side, why didn't you pass the wire from the proximal pole through the graft into the proximal fragment? Because here the direction seems to be the other way. Seems to be coming from the trapezium side into the distal fragment, graft and proximal pole. Is there any reason why? Or
still due to the small size. Actually, it is ideal, as you said right now, it is ideal to pass wire from dorsal to volar in cases of proximal pole fracture, whether it is a K-wire or whether it is a screw. But here the pole was very, very small, and that intraoperative, I was more comfortable putting wire from the volar side. That is the only reason.
Okay, thank you.
Yeah, I request Dr. Rohan to give a closing remark. We have discussed around 11 cases, and of course, we can go on and on, but yes, Dr. Rohan.
Yeah, thank you, Parag. So it was a great session with lots of cases, good learning points for, I think, all the faculty. Firstly, I would like to thank Dr. Ashok and Dr. Neeraj and OrthoTV team for allowing us to host this webinar on their platform. Thanks again, Parag. You've been a great convener, as always, and allowed all the faculty to share their views, share their cases. Actually, we would like to apologize for the postponement of this webinar that had to happen because of technical reasons. And I'm glad that we could host it today without any mishaps. So thank you again to Parag and OrthoTV. In regards to faculty, thank you for sharing your time and all your experience. Dr. Amit Varhade from Nasik, Samrat from Nagpur, Dr. Kiran, Bipin, and myself from Mumbai. So for all the listeners and viewers, I hope you could take a lot of learning points back. If you have any doubts and questions later, you can always reach out to us. I'm sure everybody has everyone's contact. And with this, I would like to close the meeting. Thank you, everyone.
Thanks. Good night.
Yes. Thank you.
Thank you. Thank you.
Dr. Ashok, can we stop the meeting? Okay. I think we can leave the...
Ashok? Dr. Ashok? Can we stop the recording?
Let us have a screenshot.
Yeah.
Yeah, Dr. Ashok, could you stop the recording and the live relay? Oh, he may not be around. Okay.
No, I'm calling. Yeah.
Bipin has joined back on time.
Sorry?
Bipin has joined back on time. So this
I will take screenshot.
Let Ashok stop the relay. Let Dr. Ashok stop the relay.